Welcome to my presentation outlining the use of skin-to-skin care for managing procedural pain in the neonatal intensive care unit. Preterm infants face frequent painful stimuli and their pain is often poorly managed. Preterm infants are in a critical period of growth. Both untreated pain and opioids cause abnormal brain development leading to poor long-term outcomes, so non-pharmacological interventions are priority. Skin-to-skin care has been suggested because of its regulatory effects. It is known to improve stability in preterm infants and is widely accepted as safe and effective. Skin-to-skin care involves placing an unclothed baby on the mother's bare chest. I used the PICO model to build the following question. For preterm infants, is skin-to-skin care during a painful procedure more effective than standard practice at reducing pain during and immediately following the procedure? I searched the CINAHL, PubMed, ScienceDirect, and ProQuest databases for relevant articles from the year 2000 onwards. One systematic review, 4 RCTs, and 1 quasi-experimental study were reviewed, reflecting the highest levels of evidence available. Application of critical appraisal tools deemed the evidence credible and rigorous. The studies focused on stable infants 30 to 34 weeks gestation undergoing a heel lance. Pain scores were reduced up to 90 seconds following the procedure, decreased pain cues and crying noted, and a quicker return to baseline when skin-to-skin care was used. While skin-to-skin care was consistently favored, not all results were statistically significant, so can only be recommended as an adjunct therapy. NIDCAP supports individualized assessment and interventions aimed at reducing stressors in the NICU. Skin-to-skin care is a key component and is the preferred milieu for preterm infants given its documented benefits and ability to buffer external stimuli. As a result, routine skin-to-skin care is an established practice used for neuroprotection. It is feasible then to implement this intervention for all gestations. Only a select few of the most critically ill infants are deemed too unstable for transfer, in which case standard care would be provided. As an adjunct to current policy, skin-to-skin care will be used with soothers and oral sucrose. Since heel lances are not routinely performed, the intervention will be for all venous access procedures. Infants will be placed in skin-to-skin care for 30 minutes prior and 1 hour after. All infants deemed stable for routine skin-to-skin care will be included. An individualized assessment based on clinical expertise will determine suitability for transfer. Organizational support, effective leadership, and a readiness for change is necessary. A multidisciplinary approach using clear communication and shared goals will facilitate success. Some staff perceive NIDCAP as unimportant, so may reject the change. Education and involvement in the change process is critical for buy-in. Also, mothers may be reluctant to participate due to fear and a lack of knowledge. This can be addressed through counseling and anticipatory guidance. A shift to non-pharmacological interventions must be embraced. Monitoring adherence is important to identify threats to sustainability. Pain responses will be measured using a pain scale to evaluate effectiveness. Secondary outcomes are the rate of opioid use and long-term neurodevelopmental outcomes. No research exists exploring this intervention in infants younger than 28 weeks. A formal study is needed to address this gap and stimulate further inquiry. Implementing skin-to-skin care for procedural pain management reflects a commitment to improving the quality of care reflective of the best available evidence.